Morning, Stuart.
Good morning. Can you hear us in the room?
Yes, I can hear you.
Well, good morning, and Brian Dowd is here as well. Morning.
Good morning. Well, shall we begin then?
Sure, that sounds great.
All right, we'll call our care management meeting, our committee to order for April 10th. I'd like to thank everyone for attending this morning. I think I see Shane Mobley, board member Shane Mobley is attending this morning. We did have Dr. Rucker say she would not be able to attend, and I'm sure we'll have a few other folks joining in as we get started. But if we would maybe just reflect on our last meeting real quick. We met last on January 9th of 2025. And during that meeting, we had a presentation on the PACE program, which we got to hear a lot about, kind of that alternative pathway or program of all-inclusive care for the elderly, and the work that the state is doing. And I think we ended it by saying that perhaps maybe about a year from now, maybe early calendar year 2026, we might see some activity on that post RFP process, et cetera. So with that review of what we focused on in our last meeting and our minutes, Stuart, can I turn it over to you then?
Certainly, yes, happy to, and happy to tee up the conversation today, which is relevant for a number of reasons. It's interesting to have a conversation on autism spectrum disorder and ABA therapy, but it's also very timely as we are, post the redeterminations and in our Medicaid program, and looking at what are the drivers of our costs and what are the drivers of potential rate conversations with the CMOs. One of the biggest areas of growth over the past year has been the large increase in ABA therapy for members of our program. And so it felt very timely to have this conversation. This is particular to Georgia, but it's also nationwide, as there are increasing numbers of discussions around how to interact what are traditional mental health services with autism spectrum disorder. And so that conversation has been both an exciting opportunity and a challenge for most states at this point. And so thought it would be a good opportunity for Brian Dowd, our Deputy Executive Director here in the Medical Assistance Plans Division, who you all have interacted with quite a bit, to share sort of the history of the ASD benefit here and how that has developed over time. And then we can turn it over to Michael Smith, our Director of Behavioral Health here at MAP, to speak a little more about the current offerings around ASD and ABA, just so this can be an informative conversation of what is happening in Georgia on this very timely topic. So if that sounds good, we can pass it to Brian.
That sounds good. Brian, we'll let you lead off.
Great, thanks. We're going to pull up the slides. Oh, by the way, the PACE RFP did post, not to go back to the last meeting, but just so you guys are aware, it posted 2 days ago, I want to say, maybe a day ago.
Oh, very good. Thank you.
Great, thanks. So we're going to talk about I'm going to talk a little bit about the history of ASD therapy, or autism spectrum disorder therapy, which is what we call it in our Medicaid policy and what we called it. So if you go to the next slide. This is just our purpose. We start every presentation with this: improving access, ensuring quality to strengthen the communities we serve. Next slide. So just a little bit of a history lesson, not like a huge history lesson. I'm really old. So and I've been here probably way too long. So I do have a bit of the history. Back before January 1st, 2018, we did not offer as Medicaid ABA therapy or autism spectrum disorder therapy. It just wasn't a benefit in our plan. Children could get OT-PT speech, but they could not get ABA therapy. If you go back probably 10 years before 2018, 2008, 2009, there was a lot of discussion and actual pushback about ABA therapy as, you know, not being a therapy and what is this new modality, and we don't really understand it. And the state of Georgia had just never incorporated into their state plan. There was federal guidance from CMS. It was in 2016, I want to say, where there was a state Medicaid director's letter that said, hey, states, ABA therapy fits under early periodic screening, diagnosis, and treatment as one of the therapies that should be afforded to children. And it also fits, it's under the code that tells you what services have to be provided under EPSDT. So it's basically instructions to a lot of states that you need to get your ABA or autism spectrum disorder therapy program up and running. And just so you all know, Georgia was not an island. There were lots and lots of states that did not provide ASD therapy at the time. So back in spring of 2017, the governor put in his budget and got legislative approval. It was just about, if I'm not mistaken, $64 million was the number that was put in order to cover ASD therapy under Medicaid. And at that time, we started doing a lot of research. We had a change in commissioner. Commissioner Reese had gone to be an appellant Supreme Court judge, and Commissioner Berry had come in. Blake Fullenwider became our Medicaid director. And so there was a lot of moving parts here at the department. And so myself and a few other people were given the task of making sure we got the ASD therapy up and running by January 1st, 2018. At the time, the order was kind of from Governor Deal's wife, and she was real serious about it, like really serious about it. So it was very useful as a department and an interagency collaboration thing to be able to say, hey, Mrs. Deal really wants this done. So I don't know if you're going to delay it, but you're going to have to talk to Mrs. Deal. And things really got moving quite quickly. It wasn't just the Department of Community Health who had this initiative. There were budget instructions for ourselves, the Department of Public Health, the Department of Behavioral Health and Developmental Disabilities. Also, there was instructions to the Department of Education to work with us on the collaboration to stand up ABA therapy. Next slide. That's just the actual budget we used to put it in, and it went into the FY 18 and 19 budget. So again, these were the oversight agencies in 2018 that actually had ABA therapy services. There were 3 state agencies named within the budget that wanted to enhance the capacity to support people with ASD. For us, our charge was to stand up therapy. That was our charge. You need to stand up therapy by January 1st, 2018. For the Department of Behavioral Health and Developmental Disabilities, they were told you need to do crisis support services for children with autism. The Department of Public Health was given some funding to enhance early intervention and identification services. That was a lot of screening, a lot of dollars for screening for children to go into assessment. If you got a screen, then you would go for the full assessment. They were also given a lot of the public health nurses were given tools. They were given computers and laptops to actually go out into the field and into offices to do ASD screening. So that's how the money kind of floated out. But our charge at the time specifically was, we need a therapy program in the state of Georgia. It needs to be up and running by January 1st, 2018. Next slide. So what we did was we honed in, there was a lot of research. It was a multi-collaborative effort. We talked to tons of providers, people like the Marcus Center, nationwide places we went and talked to, experts in the field. We talked to a lot of family members. We talked to people like Anna Bullard, who passed Ava's law in the state of Georgia, and tons of community meetings talking to families and different ASD providers in the state. And we started with behavioral therapy as the foundation for ASD treatment, which is that ABA therapy. That included social skills development. And again, it wasn't available to 2018, before January 1st, 2018. What we were doing before that time was trying to put a round peg in a square hole by going to different therapies. Next slide. So within our research, we negotiated with CMS to have 4 practitioners to deliver therapy. The BCBAs, which is a board certified behavioral analyst. And then those are the experts in the field. They're the ones who do the supervision and do a lot of the actual work of, modifying different behaviors and therapies. And then the boots on the ground people are registered behavioral technicians. They're the ones who work with the children to implement the plan of care and the therapies. Now, we did have other practitioners, so that you guys are aware on the board, that we tried to negotiate with CMS at the time. We had some parapro language in our original submission and some other level practitioners. And at the time, CMS was not willing to accept anything other than BCBAs. We do allow higher level practitioners, psychologists and psychiatrists as well, but BCBAs and then, like BCBA BAs, which are the associates, and then RBTs. And it was actually a bit of a negotiation with CMS just to get RBTs allowed. They initially didn't really want us to have RBTs, and we said there's no way to deliver a therapy benefit with just the BCBAs. No state is doing that. And we eventually got to the place where they were good with RBTs. Next slide. So again, what we used, so the CMS guidance was from 2014. My timeline was wrong. All the things I talked about, advocates, providers, specialists. There was an autism plan for the state of Georgia that outlined all the stuff I talked about earlier, and governor's budget recommendations. We wanted to leverage the existing infrastructure of the different state agencies, making sure that we opened the ABA codes that existed within Medicaid now to leverage those codes, because those codes were what our existing provider pool was used to using. We really wanted multiple access points for families to be able to get services. We were trying our best to invest in early intervention, and we've continued to do that through 2018 by providing rate enhancements to screening for ASD therapy. We've done that a couple of times since 2018 to incentivize physicians and others to do that early screening to send to the full assessment for those kids that screen positive for ASD. And we really wanted to expand our qualified network through the enrollment of BCBAs. At the time, we had very, very few BCBAs in the state of Georgia. And all of them, practically all of them, were in the metro Atlanta area. Gwinnett, Alpharetta, up in Smyrna. That was pretty much it. So when you got to Hahira or Thomasville or even Savannah, there were no providers at the time. It was really a desert for provider care. So again, we talked, thank you for, you don't, we got other states to give us what they were including. We talked to CMS, they proposed codes, and then we did other additions to the codes based on really subject matter expert inputs, those national experts on ASD therapy. When it came to pricing, we looked at what was available in the behavioral health rehab option. So if for our mental health services, there's often tiers of reimbursement. So depending on your practitioner level, you basically get paid more. And we did the same thing here. If the RBT is delivering service, it's a different tiered level than if the BCBA or a psychologist or a psychiatrist. The other thing we did is we really tried to leverage telemedicine. We understood, and I don't know if I have this in slides, but we built a very robust rate in 2018. We understood that we had not a lot of providers. And the only way we were going to get a lot of providers is if we paid providers well. So we went with a market rate at 2018. It was the highest rate that you pay BCBAs east of the Mississippi. We paid more than any other state east of the Mississippi, and we immediately saw results from that. We saw, it's a weird historical thing, but at the same time we were introducing this, South Carolina cut their rates for ASD therapy by 40%. And Florida had a freeze on ASD therapy because of some fraud, waste, and abuse issues. So it was kind of a perfect storm. We got all these ABA therapists from South Carolina and Florida who came into our market because they were either getting price cuts in other states or they were having froze enrollment in other states, which was great for us, terrible for them. But you know, I can't worry about Florida and South Carolina. So these are those different tiered reimbursement levels I was talking about. They all get paid differently based on their educational background. And then if you go to the next slide, it just gives you the outpatient benefit for ASD therapy that we do. And I want to be clear that we provide this services in homes, we provide this service in clinic, we provide this service in school as long as it doesn't violate the IDEA Act and they are actually being used for therapy and not being used as a teaching aid. Then we also authorize it in school settings. We do require a prior authorization. We put a prior authorization webinar on our DCH website, and it's still on the Alliant website, which teaches providers step-by-step how to submit a prior authorization. We did the same thing for enrollment in the Medicaid program. Leslie Austin, our provider enrollment director, had a camera set up behind her where she typed in how to become an ASD therapist and took them step by step through the system on how to enroll. We also did 6-month increments of prior authorization, which was very generous. A lot of states do 3, some states actually do 2 and 1 month increments, which is, it seems incredibly burdensome to me. But we went with 6-month authorizations. Over the years, we've also moved out the amount of time that you can submit an authorization to 60 days before the expiration of the current one. So those were some of the things that we did thoughtfully, making sure that we were trying to get folks in the system.
Hey, Brian, can I ask a question on that? With the various levels of providers, and the authorization process, are those authorizations valid for certain levels of providers, or is there a sort of starting at a certain level and then working up to different levels, or are patients able to access, once authorized, they can access any of the tiers? Could you speak to that a little bit?
Absolutely. It's a great question. So when you do a prior authorization for ASD therapy services, it's just for the hours that are necessary on medical necessity for the services. It doesn't, the PA isn't tied to practitioner level, nor is it tied to rates. There's no rate on the PA. It's just saying Brian needs X amount of these specific services. And then if the services are all provided by a psychiatrist, we'll pay at that rate. If the services is all provided by an RBT, we'll pay at that rate. And we delineate that based on, there's a modifier on the claim code. So you may bill 91225, which I think is one of the ASD therapy codes, which is weird if I know that. And then you just add U1 to U5 to that code, and then number of units. And U1 through U5 lets us know as an agency, oh, a psychologist did this. Oh, the BCBA actually delivered this therapy. And then if it's a U5, we know the RBT delivered the therapy. But the PA just authorizes the therapy.
Got it. Thank you.
Yeah. Same thing with actually how we track whether it's in school, out of school, or in clinic. Those are also modifiers. So U6 and U7 let us know that it's not in clinic. So if we go to the next slide, this is just what the assessment services are, and there are different types of assessment services. And I think Michael's going to talk a little bit about that, so I don't really want to talk too much about it. And then same thing with treatment. If you go to the next slide, these are kind of the different buckets of therapy that we and assessments that we honed in on the state of Georgia. One other thing before I turn it over to Michael, because I think Michael's next. Yeah, he is. So we, in addition to ASD therapy, a couple of years later, I want to say 2021, we also introduced behavioral support services, because there's often a lot of confusion between what is therapy versus what is behavioral support. And we will get requests for authorization for 24 hours a day of therapy. And you can't do therapy 24 hours a day. If you talk to any expert in this field, they will tell you that is impossible. And the easiest way to think of it is no child would have 24 hours of speech therapy in a day. No child would have that. Even Marcus's intensive speech therapy program is 8 hours a day. And then that's all the children can do. That's for children with intellectual disabilities that have trouble swallowing. And so they do like a full day treatment for a couple of weeks until they get used to eating and swallowing. So we introduced a secondary service called behavioral support services that actually stands up where it's not therapy, but it's more help with activities of daily living and skill building. Not that skill building isn't part of the therapy, because it is, but it's not the intensive therapy codes. And we put that in recognizing that families needed help who had children with things like wandering behavior or aggressive behaviors. And that behavioral support services, which we're still trying to get more and more providers for, is supposed to do that back end work of helping families with the skill building and those difficult activities. That's not really the focus of therapy. Therapy is about doing the actual therapy. Okay, I'm going to turn it over because Michael can talk a lot more about therapy than me.
Thank you, Brian. Hello, everyone. Next slide, please. So a couple quick disclaimers. One, my training is as a licensed clinical social worker, not a BCBA. So when I talk about ABA, applied behavioral analysis, it's as someone whose work has been adjacent to that, particularly during my tenure at DCH. Additionally, Brian talked a lot about the service delivery. So what I'm going to talk about today is a very high level overview of ABA. I'm going to scratch the surface of it, really. It's an incredibly intricate scientific approach to behavior modification. And we just wouldn't have time enough today to be able to cover it in 15 minutes. So we often hear about ABA, and I'm not sure how many of you know specifically what ABA is, but I did not until very recently know the details of what it's about. Before I talk about ABA, I want to talk just a little bit about something that's kind of pervading the Georgia as a whole right now and many other states in the nation, and that is screening that happens for young people who might have ASD, assessment and treatment too late. Doesn't mean that the treatment is ultimately ineffective, but just means that the dependency-free life years, as you'll see on the screen, those reduce the further one goes up in age into when the ABA services are initiated. So just like anything else, the chances of having a good outcome are greatly improved the earlier you screen, assess, diagnose, and treat something. ASD is no different. The American Academy of Pediatrics recommends pretty early on, as you can see on the screen. We, in the work, the behavioral health unit at DCH and I do, we're seeing young people who are getting screened and assessed, diagnosed, treated as adolescents. And their outcomes will not be as robust as if they were screened, assessed, diagnosed, and treated as toddlers. So that's kind of the state of play for many young people across the country. And Brian talked about ways in which to induce greater screening capacity, assessment capacity within the state. And it's a challenge that we continue to take a bite out of every day. But it's really something that impacts quite a large percentage of the population. Next slide, please. Or can I? Okay, great. So ABA is an evidence-based practice, meaning it has its roots and validity in research. I am a psychoanalytically trained psychotherapist, which, if any of you know, that is much more of an art and science blend than ABA, which is very scientific, including data collection, which I'll get into in a moment. ABA is based on the science of learning and behavior, has been around for a lot longer than I thought it had been, since the 60s. It's used to increase language capacity, communication skills, attention, focus, social skills, memory, decrease problem behaviors. It can be delivered, as Brian talked about, by a variety of BCBA types, as well as registered behavior technicians. Next slide, please. It's flexible. It can be adapted to meet the needs of the unique person. It can be provided in different locations. Brian talked about the school, home, community. In fact, a large part of what ABA does is looks at the environment where the young person is and spends most of their time and really tries to design the therapies, the interventions around that specific environment. And it can, as Brian also talked about, it can be one-on-one or have group instruction. Next slide, please. So a little bit more on assessment. The assessments, as I've seen them roll out, They can be done by a handful of providers now. They include a lot of measuring, observation, um, family engagement, member engagement, um, and at the end of the assessment period, depending on the assessment type used, a treatment plan that works for the ecology of that young person, the family, the environment that young person is developed. And the treatment, of course, can have a few different domains, as you'll see on the screen. And depending on when that young person is screened, diagnosed, assessed, or treated, depends on which one of these, if not all of them, how much time, attention, data, et cetera, is spent, is looked at, is worked with. Something I just want to back up and say about ASD, and Brian, I'm not sure if this was something you covered, but ASD typically has 3 levels, level 1, level 2, and level 3. Level 1 is the most mild, 2 moderate, 3 severe. And often the treatment, ABA, can mitigate higher levels, or 1, 2, or 3. So if someone's screened, diagnosed, assessed, and treated at a young age when they have level 1, that might mitigate a shift up to level 2 or level 3. Again, the work my team and I do is often seeing young people who haven't had any treatment or assessment screening, what have you, until their adolescence and they're big enough to hurt somebody. And at that point, many of them are at levels 2 or 3. They don't have much speech capacity. They don't have many social skills. You know, in severe cases, they haven't been potty trained. They don't have many motor skills. Sometimes they don't have ambulation. So again, early screening, diagnosis, and treatment is really key in not making sure, but helping to mitigate an increase in ASD levels. I'll come back to screening, diagnosis, and treatment on and off. Next slide, please. So data collection. So once the treatment assessment's done, treatment plan is done, BCBAs, RBTs are in the milieu, whether it's the home, school, wherever, working, executing the treatment plan, and collecting data. You'll see some of the data types listed on the second bullet, how frequently a behavior happens, how long it happens, what's the time in between it happening, what happened before the behavior, what happens after the behavior, and then a mapping of the length of that whole antecedent action consequence system. And then the NOS regularly meets with family members, program staff to review the data. When we have reauthorizations for ABA or ASD services, the data has to be included in the reauthorization process to be reviewed to see if the member still requires the level of authorization that's being requested by the provider. Next slide, please. So a lot of what ABA comes down to, and I'm not a parent, I've raised a rescue pit bull. I'm not going to compare children to animals, but I will say anybody who's raised a child or tried to change behavior for anyone knows that if you do positive reinforcement, not negative reinforcement, you get better outcomes. So ABA is a lot about reinforcing what's positive, and unless there's a safety concern, severe safety concern, not reinforcing what's negative. So yes, ABA really tries to reinforce positive outcomes for young people and minimize the time spent on what the member should not be doing. Next slide, please. Um, so ABA, we often talk about it for young people who have autism. ABA is actually a pretty big tent in terms of a treatment modality. It can be used for behaviors where there's a lot of some conditions where there's a lot of reactivity in the behavior. I know some child placement agencies in Georgia who work with pretty traumatized young people use a variety of ABA techniques just to help the young person understand and think through and have options around behavior. That doesn't allay the need for trauma therapy, but it does help with some of the negotiations of day-to-day circumstances that can help keep the young people and those around them safe. Caregivers, of course, get trained throughout the day because, as Brian said, this stuff doesn't happen 24 hours a day. And yes, we do get a fair number of requests, and it's after a certain point, what folks are looking for is someone to be in the home to really help keep things quiet, but that's not treatment. Again, lots of opportunities throughout the day to work on ABA. And it says it can be effective for all ages. That is true. It is more effective the earlier you do it. Next slide, please. And then I'm not going to belabor this. These are just some types of ABA. There are several. I'll leave them up on the slide for a moment. Okay, next. Okay, and I think that brings us, to the end. Next slide. Yes, any questions, concerns
Thank
about
you,
that?
Michael. I appreciate Brian and your presentation. And Chair Williamson, happy to pass back to you for any questions you or other members of the committee may have, but appreciate everyone's attention to this and hope it was an informative conversation for you.
I thought it was, thank you, Stuart. I thought it was very informative, to kind of hear a little bit about the history and what was available, before 2018 and what became and is now available with this focused effort that kind of began back under Governor Deal's leadership and sounds like with a lot of support from Mrs. Deal. So I thought it was very informative, as well as kind of hearing about the various types of treatment and how that is carried out. I'll pause there to ask our board members if there are any questions for our group this morning on our presentation.
This is Shane Mobley. No, I don't. It was excellent. And I want to thank everyone for the hard work they put into it, but it was really, really informative. And I can't tell you how much I appreciate that. We have great people. We really do. But thank you.
Thank you, Shane. And it sounds like through this concerted effort that began only a few years ago, a lot of development has taken place. As Brian pointed out, perhaps our timing was good with things that were going on around the states around us that helped us from a provider standpoint. Brian, are we seeing the number of providers it's continuing to increase? For this in particular, would we say there's a adequate number, a shortage, or what is kind of the state now?
That's a good question. It depends on where you are in the state, right? We've actually had some of our care management organizations come to us and say, hey, we've really looked at our provider network in some of the areas, particularly like that northern band of the metro Atlanta area. We have a great number of providers for ASD therapy now. We're really We've got a lot of good providers. But when you get into some of the rural areas, when you get into the Hayhiras and the K-Rows and those areas, we still have work to do. We still have more providers that we could use in the non-metro areas. And we also have a real need for assessors, not so much those individuals that deliver the direct therapy, but really the individuals who do the assessment to verify that a child has autism. A great number of the screens that we get for autism are actually not autism. When they get in for the full assessment, we find that there may be other behavioral health issues or other things. So that's kind of where we see a little bit of the backlog in the rural areas and particularly in the assessment streams.
Okay,
That's not unusual. That's pretty much any state you go to. It's the same story.
sure. Appreciate that. Stuart, do we have anything else for this morning?
We do not today.
Okay, again, thank you to Michael, Brian, Stuart for pulling this together for us. And with that, our meeting is adjourned. Thank you.
Thank you.
Thank you.